So greetings everyone. My name is Nida Al-Madi. I'm a third year resident at KKish. This is a 3 days old post-term newborn from Saudi, a product of uncomplicated cesarean section. His mother was otherwise healthy during pregnancy. His weight at birth was 3 kg and his APGAR score was within normal. He was referred to our emergency room at KKish for further management and evaluation. The child was kept in the NICU for the first 48 hours to monitor the bilateral upper eyelid finding after delivery. Patient did not receive any treatment for the eyelids in the NICU. So upon examination, he was a healthy newborn, had normal vitals with bilateral exposed injected chemotic palpebral and forniceal conjunctiva, everted eyelids, and positive translumination and overlying yellowish discharge. The swollen conjunctiva was obscuring the view to the palpebral fissure. With difficulty, we were able to examine the globe fully using Demar retractors. The discharge was, upon examination, the globe was fully within normal. The discharge was collected for culture and stain to rule out ophthalmia neonatorium, and it came out negative. The condition was clinically diagnosed as congenital upper eyelid eversion. So initially we thought, should we empirically treat as ophthalmia neonatorium until the culture comes out? Should we surgically intervene with temporary tarsorrhaphy? Should we attempt to revert the lid back manually in the ER or treat conservatively? So what we did simply is apply 2x2 gauze dressing soaked with isotonic saline over the prolapsed conjunctiva to create an isotonic environment and a moist chamber, alongside with the antibiotic coverage and daily cleansing of the conjunctiva and the discharge. So this was the presentation of the child 3 days after the treatment. 9 months later, I had a similar case that came all the way from the southern region in Saudi, from Najran, with bilateral upper eyelid eversion, and we treated similarly with a conservative management. This was 2 days after the conservative treatment, and this was 4 days after. So simply, congenital eyelid eversion.
We'll stop right there if that's okay with you. Yeah. So Dr. El-Touki, could you share your experience and what would you have done? Could you go to the microphone, please? Yeah.
We actually had several of these cases, but we do 2 temporary tarsorrhaphies on either side of the middle line at medial and lateral the limbuses, and within few days it just resolves. So the conjunctiva needs to be inside. When it's inside, the ecchymosis will go away, everything will be fine. That's what we do.
Anybody else from the audience? Would you do anything else? We're pediatric ophthalmologists in the room, right? Any of you have seen such similar cases? So could you again, for the benefit of the audience, tell us exactly how you managed the child right from day one when it was referred to you?
So we brought a 2x2 gauze dressing, and we created an isotonic environment. In the literature, they prefer either an isotonic normal saline or an isotonic saline or a hypertonic saline, but we use the isotonic. And this causes the hyperosmotic environment, sucking all the fluid from the conjunctiva and relieving the forniceal and the palpebral conjunctiva, reverting back the eyelid again. Most of the cases, they conservatively are treated.
Right. I think that's what she's trying to say, is there was no procedure performed as such, and all you had to do was keep the conjunctiva moistened, dehydrated, is that correct, with your hypertonics,
Yes.
and that was enough for it to resolve. Anybody else?
I had a similar case, and same thing, Down syndrome, African descent, and she developed corneal perforation. And we had to do skin graft and tarsorrhaphy. So it doesn't always resolve only with conservative treatment.
Okay. The only issue I have is whenever you put something as abrasive as gauze, regardless of what is on the gauze itself, that itself can be quite abrasive, can cause epithelial defects, that itself can cause more discharge, which is not always an infection. So if you were to conservatively manage, you can use Tegaderm dressings or silicone films or whatever, even the cling wraps that we use in the kitchen. Just keep it moistened enough while the patient gets getting better on their own. Or like Dr. El-Touki said, in severe cases, you can do that. If the conjunctiva is moistened enough, you can even use a Dehmer retractor to kind of push things back, very similar to the conjunctival prolapse we get following supramaximal levator resection. I do it. Thankfully, I don't get much of a conjunctival prolapse. And then you're right. The challenge in pediatric babies is that you cannot do anything to close the palpebral fissure of the eye because of the development of amblyopia, especially unilateral situations. So I think that's a comment I thought I would have.
Doctor, I have a question because they mentioned in the literature that eyelid manipulation might induce the autonomic system, and hence the child might have a respiratory arrest upon manipulation of the eyelid. Would you do it under GA or while the child is awake?
I think children can take a lot. It's very similar to administering propranolol for, say, infantile hemangioma. Have a pediatrician by your side. They can handle anything. So you shouldn't have to worry about it. But we don't need a GA, you don't need sedation, you don't need anything at all. The kids are very, very tough, unlike adults.